All right, good morning, everybody. Let's go ahead and get started. I know we have a pretty full agenda today with some presentations from 4 of our state agency participants. With that, let's ask Mariah Halleck to call the roll, if you would please, Mariah.
Sure. Director Damschroeder?
Present.
Interim Director Himes? Director Corcoran?
I'm here.
Director Chris?
Present.
Administrator McLeod?
Present.
Steve Ferris? Ryan Augsburger?
Good morning.
Good morning. Holly Pendell? James Flynn?
Good morning. Present.
Latoya Peterson? Mark Totman? Mayor Murin?
Present.
And Pat Teaberry? Okay, we do have a quorum, and if any members have just joined, I know I just let a couple people in, please just let me know. Thank you.
Great. Thanks, Mariah. Again, I want to thank everybody for your continued flexibility and participating virtually or remotely. We have at least one more meeting scheduled for July, where we'll have some additional presentations. But we thought it would be a good idea to hear from the 4 of the state agencies that engage in pharmacy activities, each with different constituencies. But we thought this would be a good idea to kind of get a sense of what all different components the state is engaged in. So that will be the topic for today. I know each of the presentations are pretty detailed, and so I want to thank everybody for your work in putting together that information. So just as a reminder, before we jump in, that this is a public meeting, and even though it's being held remotely through this medium, it is being recorded and will be posted on the DAS website. All of the documents that you'll see today as a part of the various PowerPoint presentations, as well as PowerPoint presentations from previous sessions, are all archived and available to the public on the DAS website. After each presentation today, we'll have an opportunity for questions from the council as to that particular presentation, then of course any general questions at the end. So without further ado, we'll jump into our first presentation, which will be from the Department of Administrative Services, Tony Bonifilio and Greg Pollock. So Tony, I'll turn it over to you. Thank you.
Actually, Greg will be speaking on our behalf, so go ahead, Greg. Thank you.
Thank you, Director. Good morning, everyone. My name is Greg Pollock. I am the benefits manager for the state of Ohio, responsible for overseeing the pharmacy program and pharmacy benefits for state of Ohio employees. Next slide, please. To provide a very high-level overview, we have 110,000 covered lives made up of 44,000 state employees and 66,000 dependents. Our program has a 4-tier copay structure, which is generic, formulary brand, non-formulary brand with no generic available, and non-formulary brand with a generic available. Members can get a 30-day or 90-day supply, 30-day at retail or 90-day at retail, or if they choose, there's also a 90-day mail-in program, and they can get the medications delivered to their homes. State of Ohio members have 2 different health plans to choose from, the Ohio Med PPO and the Ohio Med High Deductible Health Plan. So the way they pay for their pharmacy differs slightly based on the plan they're in. Members in the PPO They pay a flat dollar copay as set forth in the collective bargaining contract. And members in the high deductible plan will pay 100% of the cost up to their deductible, then pay 20%, which is pretty standard for a high deductible plan. Next, please. With regards to vendor management, our current vendor is OptumRx, and they provide program administration for the retail network, specialty services through Optum Specialty, as well as home delivery services, as I mentioned, and then they also manage our formulary for us. The contract we have with them is a self-insured arrangement and contains 100% pass-through pricing, including any rebates that we earn. We meet with them on a quarterly basis to go over utilization data, costs, and other information such as generic utilization, trends, and then high-cost medications and other programs we have in place. We perform an annual audit of all claims and rebates. That is done through our benefits consultant. Also, within our contract, it allows for us to perform a market check. What that does is allow us to look at the marketplace and see if there are better deals out there to be had, and we can, in a way, renegotiate the contract to take advantage of any better discounts or better pricing that is available in the market. And then finally, we do have performance guarantees in the contract, and we have an annual review of those performance guarantees done every year. Next. We currently have a lot of clinical programs in place. I'm not going to read all these, but you can see concurrent drug review, retrospective drug review. We have a new drugs to market program, an orphan drug program. We do also have a program in place for over-the-counter exclusions. If a drug is available over the counter, it is typically excluded. And then there are prior authorizations and appeals, and peer-to-peer review, which is more for the providers when they have concerns to deal with their employees. Next, please. This is some pretty high-level utilization data from fiscal year 19. We spent almost $170 million on drug costs, filling 1.2, almost 1.3 million prescriptions. Our generic utilization rate is 84.6%, which means if there's a generic available for a medication, it gets filled that way. Our trend over the past fiscal year was 5%, which for us that's good. It's a competitive trend. It's good to see the number to be in that range. The average member cost per prescription is $11.91, and then the average that the state paid per prescription is $133.13. Next. I'll open this up now for questions. If you want to go out to the website, which has a lot more detail about the copay structure and the specialty drug lists and the formulary, we ask that you go to our website at das.ohio.gov/prescription drug.
Thank you, Greg. Any questions for the DAS team on employee benefits? As a reminder, if you have a question, just unmute your phone or your line and ask away.
Hi, good morning. This is Tim Flynn.
Go ahead.
Go ahead. Yeah, this is Jim Flynn from Bricker and Eckler. On the second to last slide that had the spend and utilization data, what is the trend for 5% mean? I don't understand what that means. And then secondly, how do you benchmark or whether these are good numbers or bad numbers? What do you compare them to benchmark yourself on whether these are in a good place or a bad place?
The trend, to answer the trend question, just in total spend. So if you, the spend from FY18 was 5%. The 169 is 5% over the spend from FY18. Does that make sense?
Yep, year-over-year increase. Thank you.
Yes. Mm-hmm. And then benchmark, we use our consultant, Willis Towers Watson, to find out what national trends are, local trends are, employers that are in the same, public employers. And for a while, we were seeing prescription trends in the double digits or high single digits. So like I said, for us to be at 5%, we consider that to be a better result than we had been seeing.
And the same with the other statistics, the average state cost and the total spend, I guess, you benchmark those numbers also?
I don't know about that. I would have to get back with you on that.
Thank you.
I believe there was another question.
I had a similar question, and I guess just for the group as a whole, I don't know if Mariah sent it out. This is Mary Christina Myrna. I had sent some questions following the last meeting related to if we were looking at where, I guess, in what diagnoses categories we were having the most prescription spend. And she, just referred me to, which has provided some good information, the 2019 annual health insurance report for the state of Ohio. So that provides some good information as well.
Other questions?
Yeah, excuse me, Director Ryan Augsburger, question on just how long has the DAS structure been functioning under this manner?
Tony and Greg?
You mean the four-tier copay structure?
Yes, that's right.
Okay. I would say it goes back more than 10 years. It's been in place for a while that way. If you need exact dates, I could look that up and get an answer back to you, but it's been in place for a while.
Thank you.
And Greg, the market check component and some of those features are, how long do those go back?
Oh, actually, that's a good point. The market check is relatively new. We've only done one so far. That is a new component to our arrangement. Thank you.
Great. Other questions from the council? All right, thanks, Tony and Greg. We will move on next to the Bureau of Workers' Compensation. Dr. Miranda Williams will be doing the presentation, but I do want to see if Administrator McLeod, if you have any opening comments you want to make, or just want to directly go to Dr. Williams.
Thank you, Director Dan Schroeder. No, Miranda is going to be presenting kind of what we're doing and hopefully helpful to the group as each of these agencies do things differently. But no, thank you. Miranda can start us off.
Thank you, Administrator McLeod. My name is Miranda Williams. I am the Pharmacy Program Director at BWC. I will provide everybody today with a brief overview of our prescription drug benefit design and our administration and management of it. Just to give you a picture of the scope and the size of our program, we are responsible for the coverage of outpatient medication prescribed to treat conditions related to a work injury or illness. We covered prescription medication for 27,848 injury claims in 2019, and we observed a $53.8 million spend on prescriptions. That does not include administrative payments to our PBM, and it does not account for rebates. It only includes payments to pharmacies for prescriptions and dispensing fees. Looks like we're on the next slide already there. This is an overview of how we have structured our pharmacy program. We have the internal pharmacy program department at BWC. We utilize a pharmacy benefits manager, a pharmacy and therapeutics committee, drug utilization review, a rebate aggregator, and a pricing consultant. And I will go into each of these into further detail on the following slides. Next slide, please. This is how we have structured our internal pharmacy department at BWC. We have 12 staff members, including 2 pharmacists, including myself. We direct and manage the clinical aspects, 2 administrators to manage the technical operations, 4 nurses who process medication requests, and 4 support staff that manage our help desk. I will mention that BWC handles all prior authorization requests in-house. We do not allow our PBM to process prior authorizations for us. Next slide, please. We do utilize a pharmacy benefits manager. Our agency contracts directly with the PBM. They do not have a contract with our MCOs, so we just have a single PBM that we use. This is called a carve-out model, where we have carved the pharmacy benefit out of the medical benefit. We contract directly with our PBM. We also have a 100% transparent pass-through model, meaning every penny we pay for a prescription and dispensing fee to our PBM has to flow through directly to the pharmacy. The PBM cannot keep any of that money. So we pay our PBM with an administrative fee. We pay $15.85 per utilizing member per month. That means that whether an injured worker gets 1 prescription a month or 10 prescriptions a month, we pay the PBM $15.85. That really removes any incentive from our PBM to push refills when they're not necessary. We also pay them an hourly charge if we request functionality that is new, that does not currently exist. We do pay them an administrative fee for that as well. Next slide, please. This slide shows further detail of how we determine prescription reimbursement to pharmacies. In our PBM contract, we specify that the PBM has to achieve a certain generic effective rate. This means that all generics we reimburse for, regardless of the methodology used to determine that reimbursement, must average to a 75.6% discount off of the average wholesale price. Generics are reimbursed at the lesser of maximum allowable cost, the usual and customary, that's the amount that the pharmacy would charge a cash paying patient, or the 15% off of the average wholesale price. Regarding the maximum allowable cost list, we do utilize a MAC list provided by our PBM. However, we co-manage it. Our PBM requests BWC approval for all MAC changes before they are implemented. At the end of every quarter and yearly, we measure the PBM's performance against these guaranteed rates to ensure they are performing. We also specify that they must achieve a 15% discount off AWP for all brand drugs. Next slide, please. So an important piece to the management of our pharmacy program is drug utilization review, or DUR. DUR ensures that we only reimburse for medications when it is related to, appropriate, and medically necessary for the treatment of the allowed conditions. If medication is not related to, appropriate, or medically necessary for the treatment of the injury, BWC will deny a reimbursement. We also utilize a pharmacy and therapeutics committee. I chair that Pharmacy and Therapeutics Committee. It's made up of clinicians, 6 pharmacists and 6 physicians who are responsible for making recommendations to BWC on medication-related issues, especially the formulary. BWC manages the outpatient formulary independently. We do not allow our PBM to manage the formulary. Next slide, please. So BWC also relies on a rebate aggregator to secure money on BWC's behalf for all eligible prescriptions. The rebate aggregator is paid with an administrative fee of 5% of all monies collected for BWC. I want to mention that we do not allow our PBM to collect rebates on our behalf. That would prevent, them from making clinical recommendations to us that could potentially benefit them. That's why we chose to carve out the rebate structure from the PBM. Another valuable tool we have used over the past 5 years is a pricing consultant. They provide BWC with monthly, quarterly, and annual analysis of our pricing. And that assists us with monitoring the PBM's performance against the contract guarantees I mentioned previously, particularly the generic effective rate. It also allows us to monitor our reimbursement to pharmacies to ensure our pricing is fair, that we are not overpaying or underpaying pharmacies based on market acquisition costs. And they are also able to provide special reports that assist us in clinical decision making. And lastly, they provide reporting to benchmark our pricing to the program pricing of other public and private pharmacy programs. And that helps us make informed decisions when we are making changes to our program. Next slide, please. So I could not possibly list all of our achievements in one slide, but here are some of the highlights from the past decade. We established a pharmacy program department and a pharmacy and therapeutics committee and a closed formulary in 2011. We transitioned prior authorization processing from the PBM to in-house. And we achieved a 60% reduction in prescription spend. So we went from 134 million to 54 million. And this is really multifactorial, but what has really driven the decline in spend is, one, more efficient prescription pricing. So that means we're paying less per tablet or per capsule or per unit of medication. We've also seen less frequent prescribing and smaller prescriptions. So when doctors do prescribe, they're not prescribing as much as they used to. And also a decline in the rate of new injury claims. And what I will end on today is something really fantastic. We've seen a 70% reduction in opioid prescriptions since 2011. Again, this is multifactorial. Of course, there's increased awareness from prescribers and patients, multiple efforts from other agencies in the state medical board, increased monitoring and enforcement. Those all factor in. BWC established an Ohio Administrative Code requirements that must be met in order for BWC to reimburse for opioids. They do align with the state medical board's rule and also with best practices. And at BWC, we are reviewing all claims to ensure compliance. And if a prescriber is not compliant, BWC will no longer reimburse for opioids in that claim. So that is a very quick overview of our program. If you can move to the next slide, please. I would be happy to take any questions at this time. And I've also included my contact information and how to contact our pharmacy department if any questions come up later.
Great. Thank you, Dr. Williams. Any questions?
Question from Ryan.
Go ahead, Ryan, and then we'll go to Director Corcoran.
Ryan Augsburger, thank you. Question, so you've got kind of 6 different tiers of checks and balances there. It seems like some of them intended to check some of the common abuses that some have read in PBMs. How long has that structure taken to evolve at BWC?
Our pharmacy program was developed in 2011. So really all of this has evolved over the past, 9 years. The pricing consultant that we utilize to monitor some of these contract guarantees, we started our contract with the pricing consultant began in 2015. So for about 5 years.
Thank you.
Director Corcoran, did I hear you had a question?
Yes, thank you, Director. Just a comment. The work that you have done to reduce your overall utilization of opiates is just phenomenal. And I just want to especially call it out again. You have just done an incredible job.
Thank you, Director Corcoran.
Mayor Christina Mern here. When you look at 60% reduction in prescription spend, has that been related to an overall decrease in prescription utilization? Or I guess can you just provide a little more insight on that?
Sure. There were multiple driving factors for that reduction. One thing, we've experienced in BWC that some of the other agencies may have not experienced is the decline in number of claims. So there has been a reduction in the rate of new injury claims over the years. We have seen less frequent prescribing. So when there is an injury, doctors are not prescribing as frequently, and the prescriptions that they do prescribe are smaller. So they're writing for smaller quantities. And lastly, we've also seen more efficient prescription pricing. So what we pay per unit of medication, like per tablet, per capsule, has become more efficient over the past few years. So all of those together have contributed to that 60% reduction.
Perfect. That's great. So then have you, I guess, seen a semi-correlated increase in some of your spend related to like physical therapy?
I can't speak to that today because I do not have the data in front of me, but I would be happy to if you would like to email me your question, I can direct you to the correct people here at BWC that can answer that for you.
All right, thank you.
Sure.
Other questions or comments? All right, hearing none, we will move on next to the presentation from the Department of Medicaid, and Director Corcoran will be making the presentation on behalf of her agency. Director Corcoran.
Very good. Thank you, Director, and thanks to all of you today for spending time with us. So I am the Director of Medicaid, and I'm joined today by Dr. Wharton and Tracy Archibald from our pharmacy team. Next slide. So Ohio Medicaid serves about 2.8 million Ohioans, more than 90% of whom participate in a mandatory managed care arrangement under contract with 6 managed care organizations across Ohio. Approximately 50 million prescriptions are ordered each year, and at a total spend of about $3.5 billion, and approximately 50% of that is returned to the state in rebates. Next slide. Obviously, pharmacy plays a pretty critical role in the overall delivery of our healthcare services, and in particular, our emphasis is on controlling and containing prescription drug costs at the same time that we're focused on providing access to quality medications and the associated pharmacy services. Just briefly, you have here a few of the changes in the program over the last couple of years. In January of last year, we implemented the pass-through pricing from a previous spread pricing model. And beginning then and continuing today, we have made and continue to make significant changes in our provider agreement or our contract with the managed care plans in order to both implement that pass-through model, but to continue to work on increasing transparency, pricing schedules, providing greater insight to subcontracting and downstream arrangements, delegation, and the like. And we, along with all other Medicaid programs across the country, focusing more on specialty pharmacies as well. Earlier this year, we implemented a unified preferred drug list. It's implemented consistently across the managed care plans and with our fee-for-service program. And that'll result in savings of approximately $59 million for state fiscal 21. We also were mandated by the budget bill last year to implement a drug pricing benchmark that requires us to establish a benchmark and then to identify drugs that would significantly contribute to increased spending within the program, and then gives us authority to negotiate additional supplemental rebates if necessary. And finally, if you go to the next slide, we've implemented a pharmacy dashboard. Here you see just one screen scrape that is publicly available, and it identifies a variety of different metrics. Each of the boxes on the bottom right and the upper left are drop-down boxes that allow you to look at different kinds of metrics associated with spending or prescriptions or types of prescriptions, cost per prescription, as well as total quarterly spending, and a variety of other factors, not only specific to individual managed care plans, as you see in the upper right and lower left, but also to look at major kind of overall trends, as you see in the bottom right example. Again, all of this is public and is available with all these different drop downs that you can choose to look at some of our overall statistics. Next slide. So currently, our major work is around the development of a single pharmacy benefit manager. We are in that process, and late last year in October, we released a request for information. And then later last year in November, we conducted interviews with those who responded to the RFI, both those who were interested in bidding, as well as those who were not necessarily interested in bidding, but had things that they felt were important for us to understand as we were undertaking the procurement. So the procurement is ongoing, and we are currently in a quiet period. So any additional information from the department about the single PBM or our procurement can only be done in a public manner in order to maintain the integrity of the bidding process. Next slide. But I want to say a little bit from kind of the macro design point of view. So here you have on the right illustrated our 6 managed care plans, each of which contract with a pharmacy benefit manager. And then we, the department, also contract with a PBA for the fee-for-service program. Next slide. And as you've just heard from my colleagues at BWC and DAS, both of them operate a medical program, but also provide their pharmacy services through a single PBM contract. Next slide. So our approach, or the procurement that we're undertaking, is really very much in line with the way other major programs that are operated by the state occur, that being use a variety of different medical benefit providers or managed care plans in our case, and then to contract with a single PBM for the pharmacy services. Next slide. So I want to take a couple of minutes to highlight some of the big issues that are in front of us. So these are the kinds of things that are on our plate or are in the offing that I wanted to raise, particularly for the consideration of this committee. Next slide. So the first is the issue of pharmacists as providers. Excuse me. Senate Bill 265 provided the Department of Medicaid the option, by providing permissive authority for us to enroll pharmacists as providers for a limited array of clinical services consistent with their scope of practice. And you see some examples there. So it's important to make the distinction here between, obviously, we currently contract with a large number of pharmacies, who are reimbursed for some services, particularly vaccinations, as well as for a variety of prescription and other kinds of pharmacy services. But in addition, the option of provided by 265 will further our overall objective of being able to utilize the clinical services of the pharmacist to provide things such as comprehensive drug management, medication management, and much more hands-on assistance to those in our program. But currently today, we're not able to enroll each pharmacist as an individual Medicaid program. Next slide. So I wanted to make a couple of announcements in this regard. First, our new rules for the pharmacist as provider will be posted within the next 2 weeks, and we'll look forward to input and discussion about that. Obviously, this kind of a change requires us to go through certain approval processes with CMS, which we're undertaking. And we have projected that we will go live on January 15th of next year. Currently, 3 of the managed care plans that we contract with are themselves conducting pilots with pharmacists as providers. And so this is very much consistent with the messages that we've been communicating really since the budget last year and before. However, due to some of the concerns that have been raised by stakeholders, particularly as it relates to the amount of time that it's taking for us to do this, we have pulled this out of the lineup and made it, put it on a little bit of a faster track that will allow us to implement this, but it'll be done in advance of our new provider network module and centralized credentialing. I also think it's important to point out, though, that we also know that it will take pharmacists and pharmacies some time to prepare. And in that regard, I'm thinking specifically of, this sort of a claim is filed on a medical claim or professional or medical claim. That's not typically what pharmacies or pharmacists utilize today. So there'll be a learning and an upgrading of their own systems in order to handle the billing and coding changes. They'll need to implement an electronic health record, and certainly depending on the different setup and ways in which the pharmacy operates, there may be some other work process changes or clinical workflow changes that they'll want to make in order to be able to provide more individualized services to individuals. Next slide. So often I get the question of, why does it take so long to implement this, and why can't you just give a pharmacist a number? And so I drew this rather crude picture to illustrate that if you look at the little person in the middle, whenever we create a new provider type, which is what this requires of us, it requires us to be able throughout the entirety of the Medicaid infrastructure and systems to be able to look at that individual and to answer a number of key questions and to be able to interact with that information across the components of the system. So we have to be able to recognize who is this person and what are they, a pharmacist in this case, to verify their credentials to be sure that they have the licensing or whatever other professional credentials are required depending on the type of provider, to recognize their NPI number, and then using that information to be able to check and cross-check in different parts of the system to verify what kind of reimbursement this particular type of provider is allowed to request, and then to verify the types of codes that are allowed and the associated reimbursement. And all of this obviously takes place against the backdrop of a fee-for-service program and today the 6 managed care plans. Next slide. So here is the more complicated way of saying what I've just shown you in my stick man. And obviously, while it certainly makes sense to me that it seems like it should be simpler, this is as good a representation as I can give you about why these kinds of changes are unfortunately pretty complicated and take some time within Medicaid. Next slide. So I'd like to talk for just a minute about the 340B program. And as probably most of you know, this is a federally regulated drug program that offers discounted prices on drugs to certain safety net providers in exchange for those savings being reinvested under certain circumstances, being reinvested in underserved or uninsured individuals. Ohio Medicaid contracts today with about 1,125 340B entities, as you see on the right side of your screen. And you can see that while the most common, or those that we most often attribute to a 340B status, federally qualified health centers, are in fact 206 of those providers. But you'll also notice that we contract with 715 hospitals who are also 340B entities. And obviously that number includes quite a large number even outside the state of Ohio, just as examples. In calendar year 2018, it's 340B drug purchases, I should say, across the country totaled about $24 billion, and approximately 87% of that was made by hospitals. So you can see here is just one citation from the GAO report. This particular statistics illustrates that since the time of 2009, the 340B drug purchases have grown by over 600%. And so you can imagine why the GAO and other external regulatory bodies are paying quite a bit of attention to 340B, and why we as a program take this pretty seriously. In this regard, because of some of the conversations that are underway about 340B, I feel like this is an opportune time to just point out that when it comes to 340B, we have three primary objectives as the program, the Medicaid program for Ohio. The first is always, of course, to achieve the department and the governor's policy objectives. And here you can see that some of that discussion is about how savings are utilized or different types of providers. And I'm sure that we'll be continuing to have more of that conversation. But it's also important to point out the other two objectives that I've noted here. First, that given the size of the program, there is a liability and a risk that we take seriously, of course, and want to be sensitive to limiting to the greatest extent possible. And in order to do that, it ensures a certain degree of transparency and accountability be maintained throughout the program. Next slide. So here is a diagram of our program today. And you can see that the orange arrow represents the flow of information between and among the various entities or partners, managed care plans, contract pharmacies, specialty pharmacies, the member themselves, the health system or the hospital, the wholesaler, et cetera, et cetera. The green arrow then is the flow of money between and among those different parties. And the black arrows represent areas where today are blind spots for us. So you can see that where the red question marks are, that these are areas that are not sufficiently transparent for these questions to be able to be fully answered. And part of the reason why I wanted to flag this as a topic for today is just to lay out or to enable you to see the full picture of the 340B program as it currently operates in Ohio. Next slide. And then once again, to try to simplify it or put it into terms as easy as I can understand them, you have at the top, of course, the state or the Department of Medicaid in this case, and the department can either spend less or the department can spend more. On the left side, if the department, in order for the department to spend less or under that circumstance, the department pays for medications and is able to then recoup approximately a 50% rebate. On the right side, when we're dealing with 340B entities, we reimburse the entity at closer to 100%. The entity is then able to buy the drug at somewhere between a 25 to 50% reduction in price. and the spread pricing then is reinvested into the public purchase purposes that I mentioned earlier. So at the end of the day, this is kind of the simple way that we think about it in terms of the impact overall on the program. Next slide. Another pretty hot topic for Medicaid, and certainly across the field, is that of high-cost drugs. And remember that the Medicaid program is part of the federal Medicaid drug rebate program that requires the Medicaid program to cover all of a manufacturer's medications if they participate in the federal rebate program with CMS at the federal level. So we don't have a choice about excluding certain medications. Today, most currently, the popular topic is biosimilars and gene therapies. And you have here two examples: Zolgensma, a drug that treats SMA, costs about $2.1 million per dose, and a new one that's in the pipeline, referred to as known today as Valrox, which treats hemophilia A, and expecting the price to be somewhere between $2 and $3 million. Now, in part because I'm a nurse, back in the budget process, even last summer, I said to the committee, it's very hard for me not to be just completely awestruck by the miracle of these medications. Imagine having a little child with SMA and having that child be cured, literally cured, with that medication. I mean, it is nothing short of a miracle of modern times. But obviously, the price is also weighs heavily on the Medicaid programs across the country. And more often, these very expensive medications they certainly do fall on individual commercial insurers, but they do tend to fall disproportionately on the Medicaid program. And a final word about this has to do with what are popularly referred to as value-based purchasing arrangements. So in order for a state to make any kind of a special arrangement for or value-based arrangement for these kinds of medications, we're not allowed to do it within our normal course of business. It requires typically an 1135 waiver, which has accompanying it extraordinarily complex financial and clinical arrangements, all of which has to be negotiated individually for that drug and put into a waiver through an extensive process with the federal government. And a number of states are doing these or are looking at these in an even greater way. The one comment that I wanted to leave, though, in this area is typically, as I look at some of the value-based arrangements that are out there, it doesn't really speak to the overall cost that's being put on the drug or the price being put on the drug by the manufacturer. Rather, from my vantage point, it looks a little bit more like layaway, that I can pay in several installments for the same drug or for the drug, but the overall cost of it typically remains the same. So these are new. They're being used in a number of states. They are quite complicated to use, and that is a popular topic these days. So just one or two more things. I want to mention one other issue and then make one announcement. Next slide. So the last item that I wanted to provide a little bit of an update on is in the budget bill, we also received funding in these amounts, as you see here, to implement a tiered dispensing fee. And so the update that I wanted to provide today is, as everyone knows, as we look at state fiscal 21, we're looking at a deficit of $2.4 billion for the state. And so Medicaid, along with all of our partner and sister agencies, is looking at a variety of different options or ways in which our budget will be better managed in this environment. And so you see here a list of what I'll call kind of the typical list of things that every Medicaid department knows they have to do when they have to make significant budget cuts. And as you know, we've already announced managed care rate reductions. We've already announced administrative cuts. We're looking further at all of these as we move into state fiscal 2021. And last, if you can go to the last slide, I also want to make one final announcement today. The governor recently was in one of his press conferences talked about the importance of testing for COVID-19, and in particular his commitment to working with the pharmacies to enable billing for COVID testing. And so I'm pleased today to be able to announce that beginning next week, pharmacies will be able to bill for COVID-19 testing. Pharmacists will be able to administer the test using the pharmacy's NPI, very similar to how we handle vaccinations today. Claims will be submitted then through the same process utilized, and we're working with the managed care organizations in order to assure a consistent statewide implementation of COVID testing. So with that, I know I've gone a little bit over time, Director, but I'll turn it back over to you, Director Damschroeder.
No problem. All very important information. So thank you very much, Director Corcoran. Any questions from the council? All right. Well, hearing none, thank you, Director Corcoran.
Glad to. Thank you.
And next, our last agency presentation comes from the Department of Mental Health and Addiction Services. Brandon Haas will be leading the presentation, but first want to turn to Director Chris, who I think may still be on the line, to see if you have any opening comments that you'd like to make before turning it over to Brandon.
Good morning, Director Damschroeder. How are you?
Great.
Good. We appreciate the chance to present here this morning, and Brandon leads our pharmacy services, and you are in capable hands with his presentation. So I'll turn it right over to him.
Thanks.
Thanks.
Brandon.
Okay, thank you, Director Chris, and thank you, Director Damschroeder, for inviting me to present this today. Kind of just a little bit of a change of gears today, or from my presentation to the rest. So far, we've kind of dealt with managed care, benefit management, and the pharmacy benefit in particular, whereas at OPS, Ohio Pharmacy Services, what we do is more procurement and distribution, and a little more of the filling of the prescriptions and getting them, to the patients. So a little different from the previous presentations. But just to start, in case you hear me say OPS, that will be referring to Ohio Pharmacy Services. And if I say MHAS, that is our Department of Mental Health and Addiction Services. And we also work closely with the Department of Rehabilitation and Correction, so that might be DRC if I throw those out there. And to begin, the Ohio Department of Mental Health and Addiction Services provides pharmacy products and services through Ohio Pharmacy Services, and also directly to patients through our 6 regional psychiatric hospitals. So that's kind of our contact points to serve the patients and agencies that we support. OPS is a centralized procurement and distribution operation. We're in MHAS in the administrative office. Up until 2015, our office was known as the Office of Support Services. So OPS is still relatively new, but we've been around for several decades previously as the Office of Support Services. And kind of the genesis of how OPS evolved over the years was, several decades ago, there were many more mental health hospitals, and just anything from laundry to Xeroxing, fleet management. OSS used to kind of do a little bit of all of that, and then over the years, DAS has kind of picked up more centrally some of those things, and some of those things have been privatized. and we've kind of specialized in the pharmacy-related products and services, and so that's why in 2015 the name was changed. We're authorized by Ohio Revised Code Section 5119.44 to provide goods and services to eligible participants, and those participants would include state facilities, state agencies, local government agencies, community health providers, free clinics, county jails, and other nonprofit organizations. OPS operates on a not-for-profit basis and receive no general revenue funds. Everything that we operate off of is basically earned by providing the services and products that our eligible participants would need anyway. And we just try and do it as cost effectively as we can to save everyone money. But nothing in the budget is specifically GRF funds for us. We have 3 operating units licensed with the Ohio Board of Pharmacy. The Pharmacy Service Center is our warehouse wholesale operation. Most of the state entities know it as the central warehouse, but that's a typical pharmaceutical wholesaler. We also provide medical supplies, commissary items for DRC, and some forms and things that it's easier for us to manage ordering through OPI and then stocking, so then customers that use those can get them from us without that lead time that printed products typically have. We also have our central pharmacy inpatient, which is a centralized pharmacy that fills for 25 of the DRC facilities centrally in Columbus. And then we also staff a pharmacy at the Franklin Medical Center for DRC. We also have Central Pharmacy Outpatient, which is a separate licensed pharmacy, and they are primarily like a mail order pharmacy for mental health clinics, and that population that includes the mental health clinics that our Adams Board supports, and sometimes it's a primary source for some of those patients that don't necessarily have a stable residence or location. So it's a vital connection point to get them access to medications. And then also at OPS, we have a transportation department. So Monday through Friday, we've got a fleet of 15 vehicles. They make 8 daily routes Monday through Friday, average about 73 stops per day, with each route traveling between 200 and 450 miles per day. And then if we go to the next slide, please. And then this slide is just the first 2 pages of the procurement policy, but OPS is one of the requisite procurement programs in the DAS procurement policy. And so for these programs, administrative law and rule say that state agencies must purchase from these requisite programs for any of the items that they sell. So just this is pointing out that we're one of them, and if you wanted to reference the policy, that's the easiest way to find it on their website. Okay, if we go to the next slide, please. Just wanted to give you a little bit more of the details about our pharmacy operations and specifics. So our central pharmacy inpatient, this is data for calendar year 2019, but primarily still for DRC, and actually trimmed down the prescriptions, streamlining the order process with DRC. I think 2018, it was just under 900,000 prescriptions that were processed, so it's down a little bit, and that's just identifying efficiencies with them. And we work very closely with DRC on their P&T committees and with their doctors and their health administrators to make sure we're taking the best care of those patients as we can. But we also fill for halfway houses and community behavioral correctional facilities, community-based correctional facilities in a few communities. And then the Department of Youth Services has 3 facilities that we central fill for. And then occasionally we'll get jails that we can fill for. Most of those tend to go through our outpatient because they aren't as frequent, but there is one in 2019 that has been a more permanent relationship where we fill for them. And then the picture there at the bottom, that's an actual picture from a few years ago, and then that's our robots in our inpatient pharmacy. We have 10 of them, and they fill everything in the blister cards for easier tracking and accountability inside the facilities for DRC. And they're pretty much running whenever we're in there, so it's a constant buzz of those machines producing cards for us. And next slide, please. And then for our outpatient pharmacy, this is a much smaller operation, but it tends to get those patients that are more difficult to get in the other kind of safety net of providers. So a lot of these patients that these clinics see are usually in between kind of coverage on the managed care or Medicaid. So this is a very important access point for them. Our outpatient pharmacy does also fill for DRC when inmates are released. They get a supply of medication to transition them into the community. So that's part of what they do also. And then just kind of recently, we used to fill all the halfway house prescriptions in inpatient, but it just made more sense to move that over to outpatient with how that had developed. So that's why it's on both, but moving forward, they're all done by outpatient. Every year, our operations do kind of a basic price check just to see where the market is and how we fit into it. So I think this slide here in particular is important for people that aren't as familiar with the pharmacy kind of world. It's not as simple as it appears in this chart, but I think it does illustrate a few really important things to try and make sure we're understanding in this bigger conversation. So our pharmacies basically function with well-defined formulary lists. So this is just an example that when you have a formulary and use it, you can have a pretty good control of the cost. Not every situation can control what is being prescribed as well as we can in ours with our two operations, but that's just another way that formulary management can have a significant impact. I think just to kind of explain this slide, so our outpatient pharmacy manager, she every year evaluates what the market is just by calling up local pharmacies and asking, what's your price for this quantity of this drug? So that's your first caveat, is these would be your kind of cash prices, not necessarily what would be showing up in a managed care pharmacy benefit type report. And then kind of the next thing is for outpatients numbers. This is our total numbers. So we're a mail order operation. So this would be including mailing it or delivering it to the clinic where the patient could get it. So that's kind of an added cost that necessarily or probably isn't in the cash prices for the other quotes there. But that's where I think a lot of people think of prescription drugs as a commodity or a widget, and if it's drug X, everyone's going to basically pay about the same price and should charge basically about the same price. But just the complexity of the market and how it works, it's very far from commodity style pricing. I think a lot of people don't realize that, and then that's one of the big things to understand in this talk. And just an example, so the specific drugs listed there at the bottom with the different prices, I think that's to help illustrate that, those bottom three are very common, been around as generic for a while. They're very cheap, but depending on, what pricing formula you're using and sometimes depending on which drugs is selected and the AWP price associated with it, you can get some big swings in what the actual price would be. And so just as an example, I think that top line there, that's a generic for Seroquel. And if you look at the price swing in that, it's pretty significant. So I think the first two prices, the 37 and 18, I think, that's probably about what it should be. They're probably still making a decent amount on that, at Walmart. You know, that's not pricing them at their cost by any means. You know, but it's not a dirt cheap drug, but it's not terribly expensive. But then you look at the effect that the total quote price has just for that specific drug for those last three in that chart. You know, where did those huge numbers come from? You know, how is there that much of a swing? I think those are the things we need to be aware of and identify in this conversation. And then also, I think it also helps illustrate that, you know, one drug that is an outlier in price for whatever reason can have a huge impact on your total cost. So, you know, for example, in these quotes, Walgreens was the most expensive for the basket that we were quoting. And one of their drugs was almost $900 for a $3,800 spend. So, you know, if you take that out, maybe they swing in a different direction for some other things if you take a couple drugs out. So I think understanding what drugs are being utilized is very important when you're looking at a benefit. And just the only other point I was going to make is even though these are all generics and, you know, each one of these pharmacies would get a generic that they could fill and probably at, you know, a pretty low price compared to what's quoted even for those expensive ones. It's probably showing up like this because there's 8 WP formulas that determine those pricing quotes. And so I looked it up, and the AWP for that generic Seroquel, that top line, was a range of $54, and this is for the generics, $54 to just over $2,000 for the different brands or NDCs that are available of this product. And it seemed like most of them were in kind of that $1,600 range for 100 tablets. So AWP, if you're not sure what you're looking at, you know, it can also be manipulated a little bit, and you have to understand how that works. The NADAC estimated cost for this drug, a bottle of 100, would be about $17. So that's NADAC is the best estimate with information available to kind of get what your true cost would be of that drug. So that's kind of just to give some perspective is, you know, this drug I think has maybe 10 or 15 different manufacturers and a pretty wide spread on the AWP. And then when you have those situations, you know, if you're using AWP formulas, you know, you got to be aware of gaming, I guess, if you will, the formula that's being used, because if you should be paying 17 and you're doing a formula that's charging 2,000, you know, that can swing your cost. You know, that's just one drug. If you multiply that by, you know, entire managed care population, things can change pretty quickly in a somewhat arbitrary, you know, which manufacturer did you happen to use. So with that, I guess I don't want to go too long. So any questions? I didn't go into so much the warehouse operation. You know, like we could talk a lot about that too. But that's a quick overview of OPS. And
great. Thank you very much, Brandon. I appreciate that presentation. Any questions from the council?
Yeah, I've got a question, Brian Augsburger. Brandon, I wonder if you could just clarify, you mentioned that CPO, you guys are serving many of the DRC and some youth services entities, but not all of them. I guess I'm curious, if not you, then who's supplying their pharmacy management?
yeah, so all of the state-run, run by Department of Rehabilitation and Correction facilities, we serve them. I believe there are 3 prisons that were bid out as a private contract, and we don't do anything with them. And I'm not as familiar with the exact details of that, but the private prison systems, we aren't involved with them, but the ones that are run by DRC, we serve all of them.
Same with youth services?
Yes, I believe there's only 3 of those facilities. At one point there were a few more, but I think there's only 3 at this time.
Okay, thank you. Jails, it seemed like you had an awful lot. Are those all the jails, or are there some jails that have a county procurement office that's managing pharmaceuticals?
So the jails are a much different kind of way that's handled and organized and tracked. So we really don't do, there are a lot of jails out there and we only work with a handful, I guess is an easier way to describe it. Not that we couldn't, it's just a lot of those jails are set up in several different ways. So some contract for all of healthcare, with one entity, and then they have the nursing, the doctors, the pharmacy component all in one. And so we wouldn't do those, but really any jail could work with us. It's just that those are one of the arrangements that a lot of jails have had a local, pharmacy provider that they've worked with for years, and they don't see a reason to change. Or they've gone to that model where they're, contracting out all of healthcare, and then we don't really fit into that as much. But for the jails that we do work with, we have a couple that we do contract directly with. And it's very similar to what we do with the DRC facilities. But I would say the majority of what we do with jails would be through our outpatient pharmacy, utilizing some funds that are specifically for medications in jails in our department's MHAS budget. That there is some funding directed to jails, not necessarily to us, that some of that will go through outpatient.
Thank you.
Other questions? All right, hearing none. Thank you, Brandon, for the presentation. Are there any questions or comments from members of the council on any of today's presentations, or things you want to see at a see or hear from for a future meeting? All right, again, hearing none. I thank everybody for your time. Thank you to the individuals who presented today for your great information. And we will have minutes that Mariah will distribute via email to members of the council that we will vote to adopt as official records of the council at a future meeting. I think our next meeting, July 8th. We have some presentations scheduled, but as a final reminder, if there are any members of the council who have ideas for individuals or organizations that they would like the council to hear from, please let us know so we can get that scheduled, including any individuals or organizations who are members or represented by members on the council. We'd be more than happy to have a presentation from you. So with that, if there's anything you need to reach Mariah or I offline, please don't hesitate to do so. Otherwise, today's council meeting will stand adjourned. Thank you.
Thank you.
Thank you.
Thank you.
Thanks.
Thank
all.